All right. So tonight we're going to cover chapter 17, resuscitation and managing shock and cardiac arrest. It's a little bit longer of a chapter. Um, However, I don't think it's going to take the entire 4 hours. And if it doesn't, we're going to dive in back into respiratory a little bit. Bear with me. I will have a voice and then lose it today. Um, so we're going to get through this one baby step at a time. And so, managing shock and cardiac arrest is more than just CPR, and it's more than just starting an IV and giving fluids. It's not 1978 anymore. We don't just kill people. So, when we talk shock, the biggest thing that people always think is it's only trauma related. And that is the furthest thing from the truth. Shock comes in a bunch of different forms and it affects a bunch of different body systems. So, respiratory failure and respiratory arrest, cardiac failure, cardiac arrest, they all result in the inadequate perfusion to maintain cellular metabolism. Or, to sum that up, when you guys think of shock, I want you to think of the body's inability to adequately perfuse. So when you think shock, you think inadequate perfusion. In some way, shape, or form, something is affecting our body's ability to adequately perfuse, adequately take blood from point A to point B to pick up oxygen, to do the gas exchange, and then flow throughout the rest of the body. Our number one goal, oh, hang on, here we got people coming in. Our number one goal when we have a shock patient is we need to restore the conditions for a aerobic cellular metabolism. And what we need to remember with that is we need to restore the conditions for our body and our metabolism to work with oxygen. And there's a whole series of events that we'll go throughout this chapter, and I'll even pull up some of UH protocol to show you guys. But there's a whole series of interventions that you can do. And we look at those series of interventions as resuscitation. Resuscitation doesn't just mean CPR. It doesn't just mean, you know, the whole paramedic side of this damn computer. Resuscitation is anything that you do to, again, restore our body's ability back to its normal operating state, which is ultimately, at the end of the day, is our goal. But as ALS providers, you guys need to stop and think. You're going from BLS to ALS now. So when you think managing shock now as a basic, what do we do? Well, we bag, we do CPAP, we do chest compressions, we do direct pressure, we do tourniquets, we do breathing treatments. And that's a lot of what you're going to do as an ALS provider with the very few extra steps of an IV, fluid administration, TXA, or intubation. But now that you're becoming an ALS provider, you need to stop and understand what is our priority. What do we need to do first? You know, I see a lot of providers make the fatal mistake of their number one go-to is we have to get an IV. We have to have an IV. 99% of the time, your IV is not the first thing that you need. A lot of patients that you're going to encounter, airway. You need to manage airway. And as I said before, and I'll say again, if you do nothing other than simply manage the patient's airway, You've done everything that you needed to for that patient. And you're never going to be wrong for treating the patient that way. So understanding the priorities or the steps that need to be taken and focusing on the priorities of the situation at hand. Now, can you be that cookbook ALS provider that breaks out your protocol book and you look at it and you go, okay, I need to go this step, this step? Sure, if you want to kill somebody. Protocol is a guide. It is, it is not the end all be all. It is not you have to follow these steps or you're going to lose protocol. It's not you have to follow these steps or you're going to be in trouble. It is a guide. And sometimes you need to take two or three sections of protocol and put it together to be able to adequately treat and manage and maintain your patient. And how do we do that? Well, first of all, we have to have well-practiced skills. So when you're done with class, yeah, you're going to be able to practice on mannequins and we're going to practice and we're going to preach it and until you get out in the field and you start doing it and you find out what way works for you, well, you're not going to have well practiced skills. If you only do your skills once, twice a quarter, you may not ever develop those skills. Now, there are providers who can develop the skill set, maybe not use it for a while, dive back into EMS and they can pick up right where they left off. But they spent the time developing the skills. And then you need to be able to apply those skills to meet the patient's immediate needs. Now, when I say that, I also mean you need to be able to figure out what skill set you need to do in what order. You know, do you need to get that IV right this second before you hold pressure on the bleed? No. Do you need to get that IV before you manage that airway? No. Do you need to get that IV before you give put that patient on CPAP and give the breathing treatment? No. So you need to know what skills to use and when to use them. And to do all of this, you need to realize that you have to be able to work with your partner or whoever else is on that crew or on that call. It may be a neighboring department that you do not like. There may be someone on there you have to work with. Believe me, I do it all the freaking time. It happens. But afterwards, the way that you learn, I always call it tailboard talk. We come back, we sit on the back of the fire truck or we sit on the front of the fire truck and we talk about it. Especially with newer providers. That is one of the best ways to teach somebody, and it is also one of the best ways to learn. I do not always have time to teach as the call is going on. Can I rattle off everything we're doing and why we're doing it? Yes. But after the call, every single aspect of that call can be broke down. The thought process behind why we did what we did and when we did it can be better explained that way. So when we talk about the pathophysiology of shock, shock is the physiological insult that threatens our cellular perfusion. Again, shock is shock is simply our body's inadequate perfusion. That's all you ever need to remember. Our body is inadequately perfusing. There is something causing that. Now, can the body compensate? Absolutely. Can we compensate forever? Hell no. Your body, we can only compensate for so long. And how do we do that? How do we know that someone is compensating for the state of shock they're in? Well, it's called an assessment. And as you go on, I want you to think everybody's probably seen one. I want you to think about the septic memo that you have gone and got that has a raging UTI. Well, what is one of the things that we normally see? We normally see patients with tachycardia. I'm not talking when we're in the 130s or 140s, but I'm talking we're in that 100 up, 120 stage. Our body's heart rate goes up as a response to the infection, yes. but it's also trying to pump more so it can get more blood out. Because as we go into our various stages of shock, our body starts to vasodilate. So our container space becomes bigger. Now, I want you to think about it. You go to the store and you buy a 2 liter of pop. That 2 liter is full. You go home and you take that 2 liter and you pour it into a 4 liter bottle. Now it's half full. That is the same thing we're talking about. As our vasculature, which is what we're referring to as the container, opens up, the fluid inside doesn't grow with it. So now we're trying to pump more fluid. So we're trying to increase our afterload, but our preload is never increasing. So we're really not gaining much. But it's one of the ways we can see that the patient is compensating. Now, if there's not interventions at some point, the patient's going to die. Sometimes, and as this says, shock is sometimes described as a momentary pause in the act of dying. Now, does it mean that the patient's not going to die because, oh, we did everything? No. People die. It's a natural fact of life. Birth is the leading cause of death. So if you think that you're going to save 100% of the people out there, I hate to burst your bubble now, but it's never going to happen. So what we need to remember up to this point, inadequate perfusion. That we've got shock rounded up right with that. But some of the stages we see with shock is, like I said, our body's inadequate ability to perfuse, which is referred to as hypoperfusion. Now, when we talk perfusion, perfusion is adequate when the cells receive blood and oxygen and nutrients to make our metabolism work and to remove metabolic waste. Now, also with that, we also lose our gas exchange at some point. So we get a decreased level of oxygen, but we're getting a buildup of carbon dioxide in our body because our body is not able to adequately offload and onload the carbon dioxide and onload the oxygen. So, in order to adequately perfuse our body, we require onloading of oxygen in the red blood cells, transportation of the oxygen enriched red blood cells throughout the body to all of our tissues, and the offloading of oxygen at the tissues for use in the cells. Now, I want you to think we're going to go what everybody thinks of when they hear shock. I want you to think of a trauma patient who's profusely bleeding. So now we're losing red blood cells, which is how we carry our oxygen throughout our body. We do not have the ability to replace that in our ambulance. Now, depending on where you're at, can you call stat for them to administer blood? Yeah, sure. Are you going to wait a long time? Probably. Just because stat can be on the ground in 12 minutes doesn't mean they're going to be on the ground into the hospital in 12 minutes. But our body, so think of that patient that's hemorrhaging. Our body is losing all those red blood cells. It's losing its ability to carry oxygen throughout the body. We need to intervene with that. An IV and fluid is not the answer. Stopping the bleed is. And how do we do that? Direct pressure, tourniquets, packing the wound. If you do nothing more than apply direct pressure, apply a tourniquet, and if the tourniquet don't work, you go back to applying direct pressure, and that's all you get done, you're not wrong. You're stopping the bleed. Because all we do is we artificially increase blood pressure sometimes with an IV and fluid. All we really do with fluid administration in a hemorrhaging patient is we wash out our body's clotting factor. Now, can you administer TXA? Absolutely. Is it a great drug and does it work? Sometimes. Your body still has to have the ability to form clots in order for TXA to work. So, oh, congratulations, you hurried up, got the IV, got TXA on board while the patient was hemorrhaging. Guess what? The TXA didn't work, and you don't know why, and you fluid bolused them because the body lost all of its clotting factor. So, when we talk about all these steps, all these things that have to work in conjunction with each other, the heart is the pump of the body. When you think of the heart, think of it as the fuel pump. It is what pumps all the blood throughout the entire body. It's what sends the blood to the lungs to get oxygen, and it's what's sending the blood from the lungs to the body to drop off oxygen. The blood vessels are what provides your PVD, your peripheral vascular resistance, or your PVR, sorry. Your peripheral vascular resistance. I promise you, this is something you will see on registry. But your blood vessels are what provides your peripheral vascular resistance through the act of vasoconstriction. It is a compensatory mechanism. Oh, excuse me. It is a mechanism that we use to compensate. Now we only do it for a little while, and then we have to have a sufficient volume of blood with adequate oxygen carrying capabilities. So, what are some of the things that our body does as a compensation if we're bleeding? Well, we try to vasoconstrict, so we make our container space smaller to make better use of the blood that's inside of it. And our body tries to naturally build clots, and sometimes it works and sometimes it doesn't. But as we start going through these stages of shock, our signs and our symptoms reflect our body's attempt at compensation. Now, when we get to the later stages of shock, you will see what inadequate perfusion looks like. Our patients become pale. You'll even see their gums start to turn white. You'll see a delayed capillary refill. You'll see altered mental status. You'll see a decreased radial pulse. You'll see lower SpO2 that's really not going up with oxygen. You just see this patient become more and more fatigued, and you know that patient's circling the drain. But these five things, I promise you, are test questions, they're registry questions, they're everything questions. What is shock? What are the types of shock? Hypovolemic, distributive, cardiogenic, obstructive, and respiratory slash metabolic. Now, we will dive into all these phases of shock, or all these, I'm sorry, not phases, all these types of shock as we go through. And you'll even hear more on it when we get later on into other chapters. Hypovolemic shock is the type of shock that everybody thinks of most when we think of a shock patient. People don't usually think of this respiratory metabolic down here at the end. I want my laser pointer. Why isn't it working? Ah, go back. Oh. So, your respiratory and metabolic shock. These are the things that people do not think about when they think about shock. And it's the most common type of shock that you see. These are our sick patients. These are our septic, our acidotic patients. And believe it or not, yes, it is a type of shock. So, all these little lovely mechanisms of shock, your distributive shock, septic, neurogenic, anaphylactic. Now take this septic shock and I want you to put it down here with metabolic and respiratory as well. And there's a reason why. And we're going to get into it later on. Don't think that I'm a complete moron yet. But as we break some of these down, so we look at hypovolemic. You have hemorrhagic, non-hemorrhagic, which is like burns. So when you get burnt, your body loses fluid. Your body then It doesn't have the fluid in its interstitial spaces to go through the body. It doesn't have the cell, the fluid in the cells and the vasculature to go through the body, which causes hypovolemic shock. Someone gets shot, someone gets stabbed, someone gets cut, someone has something burst inside of their body, whatever the case may be. They fall down and they're bleeding internally. Hemorrhagic shock. When we think cardiogenic shock, so bad heart attacks, CHF, beta blockers, and calcium channel blockers. Something we'll get into more when we get into cardiology. An abnormal cardiac rhythm. So, your body, when we get these funky rhythms and they're too fast or too slow or very irregular, it's in a form of shock, which is called cardiogenic shock. Obstructive shock. Things like attention pneumothorax, pulmonary embolism, pericardial tamponade, your metabolic and respiratory, disturbances in oxygen diffusion, carrying, offloading, or use by the cells. Also can be caused by sepsis. Give me 2 seconds and I'll be right back. I'm going to go implement. Okay, I can breathe again. We're good. So, all of these lovely types of shock. Now, do you need to know all of them? At some point, yes. Is it going to help? Yes. But when you start to relate these forms of shock to patients and to illnesses and to injuries, what I want you to do is I want you to start thinking of what all these are. What is a pulmonary embolism? It's a blood clot. So, clotting can be obstructive shock. Anaphylaxis can be a distributive shock. I want you guys to be able to start thinking of why. And that way, when we get to all these things, even in this chapter and later on chapters and other chapters we've already covered, you can start to connect the dots before they're connected for you. you know, Again, we'll connect the dots in class, but that way you're already starting that whole critical process, that critical thinking process. So, when we get into trauma and we start talking about that hemorrhaging patient, you're instantly thinking hypovolemic shock. You know, um, when we get into cardiology here very, very actually next week, and we start talking about beta blockers and calcium channel blockers and the possibility of beta blocker, calcium channel blocker overdoses, you're instantly thinking cardiogenic shock. It's going to greatly help you. Now, I'm not going to read each and every one of these. It's a waste of your time, honestly. But these tables will give you descriptions and signs and symptoms and some of the management properties of each type of shock. Now, with that said, can you go back and make notes over them? Yes. Can you go back and watch this video? Absolutely. But I'm going to hone in on this one for a minute. So, hypovolemic shock, you instantly see right here fluid loss. So many people think that means I need to stick this person with the biggest IV I possibly can and dump all the fluid in the world into him. And incorrect. No, absolutely not. Why? Because pink blood is not blood. It doesn't have fluid, does not have oxygen carrying capabilities. And I don't know if you've realized it yet or not, but each and every slide has said in order to have adequate perfusion, you have to have oxygen. So if we go in and we wash out all of our clotting factor and we dilute this blood, we don't carry oxygen very well. Let's see. So, one of the other things where people kind of, I don't want to say mess up, but one of the areas people do struggle is um, they kind of, I guess you could say, mix up the different types of shock. I will tell you from personal experience, when I went to medic school, we had to write all of these out. We had the same freaking blocks in our book. I've had students correlate them by color. So, red for cardiology, blue for this, green for this, blah, 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 blah. Whatever works for you. Um, so one of the things I'm going to point out with this slide, you heard me say preload, afterload a little bit ago. Um, so when you look at cardiogenic shock, and again, we'll get more into this when we get into cardiology, so I'm going to kind of shorten this one up. When we have this patient and they're a cardiogenic shock patient for whatever reason it may be. This is where an assessment really comes into play. And actually, let's change it up. Let's just say we have a very sick patient. Let's say we have a septic patient for a minute. And they're not quite cardiogenic shock yet. But we don't obtain a proper medical history on this patient because it's 2 o'clock in the morning. We're coming out of the nursing home. We're pissed off that we're there. I was just sleeping real good, just got my boots off, just got in bed, whatever the case may be. And we get the patient in the truck and we do a half-ass assessment on the way to the hospital. And the blood pressure comes up 80 over 50. So you do your due diligence, you start your IV, you get an 18 in them, you start dropping fluid. Well, the nursing home paperwork sitting right next to you, you didn't really read it. Well, on that paperwork is congestive heart failure. Well, now guess what? Now you might be dealing with two forms of shock because now you might be throwing this patient into CHF, which also now is going to cause a cardiac output problem, which is going to have a issue with your preload afterload. This is where I hate this statement. IV fluids may help increase preload and increase cardiac output. Yeah, can it? Yes. Does it? Yes. Does it help? Yeah, sometimes. Don't get me wrong. Sometimes it definitely does help. But I want to say probably close to 45 to 50% of the time, there you get these two types of providers. And they're on way opposite ends of the spectrum. And as soon as I say this, you're instantly going to think of these two types of providers. Way over out in far left field, you have the provider that doesn't really pay attention, will give every single patient fluid no matter what. No matter what their medical history, they're dumping fluid into them. Way over here in right field, you have that person who go, absolutely not. This patient does not get IV fluids. They have CHF. Are they both completely wrong? Yes. Because can your CHF patient have fluid? Abso-freaking-lutely. Do you need to do your job and reassess this patient a little bit more often? Absolutely. So again, you have these two opposite ends of the spectrum on that stance, and I want you guys to learn to be smack dab in the middle of that, knowing that not every patient needs fluid, but CHF patients can still have fluid in moderation with proper assessment. It's one of my pet peeves because I had a medic student with me that was in capstone one time. So, for those that don't know what capstone is you get to be the lead provider on the truck. So, we're supposed to take a step back. And we had a hypotensive patient coming out of a nursing home, a shithole nursing home, but still a nursing home. We're 2.5 minutes away from St. E's, Maine, and we're sitting there. Now, this patient is sicker than hell, like sick to the point that I'm not a priest and I'll give last rites to this patient. I'm like, we just need to go to the hospital. Like, call report, let's go. Vitals are shit. We've taken the monitor in with us, all this. And we're sitting around, screwing around on scene, trying to get this IV. And finally, I said, what? Now, everybody, excuse my language for a minute. Please don't take offense. What in the flying bleep are you going to do with that IV? What are you going to do in a 0.7 mile transport with that IV? I got to get fluid into him. Well, okay. Did you listen to lung? I said, did you listen to lung sounds? I said, but wait, did you even listen to the patient who is almost sitting upright and sounds like they're drowning? I mean, just gurgling like there is no to freaking tomorrow. They never stopped to pay attention to pulse ox. They never stopped to think about putting this patient on CPAP. Now, did we have him on CPAP when we got to the hospital? Yes. It takes 30 seconds. Did we end up getting the IV? Yeah, as we was pulling into the parking lot. But he was so hell bent on the blood pressure, he never did any other type of assessment. And we walked out of the hospital, and he goes, "Well, how do you think I did?" I said, "I think you're a moron. 95% of our ALS duties, our job, is performing a BLS assessment. Isn't that kind of weird? It's still BLS before ALS. CPAP is a BLS function. Listening to lung sounds, a BLS function. Noting that there is +3 pitting edema, BLS function. Did the patient need their blood pressure brought up? Yes, but it surely in the hell wasn't by 0.9% normal saline solution. Absolutely not. They needed vasopressors. They needed a lot of things. The 2,000 mLs of fluid that it probably would have taken them to get to a decent blood pressure was absolutely not it. But now I'm going to say it now. Some of you may be thinking, well, wait a second. Patient was hypotensive. You put him on CPAP. Yeah. Again, something we're going to get into the more we go through class. But going back, so here, our patient not only was septic, but was CHFing. So they have the buildup of fluid. So we have pulmonary edema. And we used CPAP to fix the problem. So again, assessment comes before anything, and clear back to that second slide we covered, having a proficiency in your skill set and knowing when to use it. I promise you, if when you leave class, if you can do 3 big things, you will be one of the best ALS providers. If you can tell me why you should not do the skill, why you should do the skill, and what the benefit from the skill is, well, I should say benefit and contraindication of the skill. But if you could tell me mainly the two things of why we should and why we shouldn't do something, and what risks outweigh what rewards, or what rewards outweigh what risks, you're going to be leaps and bounds ahead of people because your ability to recognize what your patient does need versus doesn't need is key. Everything else falls into place after that. But as we break down some of these shocks, hypovolemic shock is the decrease in vascular volume. It's common in the pre-hospital setting, and it can result, again, from medical or trauma conditions. Hemorrhagic shock is obviously the significant blood loss. It is the overall loss of volume and the ability to carry oxygen. So remember, binds with red blood cells, and then the body, via use of the pump, aka the heart, distributes it through the body. Well, when you bleed out, you lose your red blood cells. You lose the ability to carry oxygen. Non-hemorrhagic hypovolemic shock, you can lose fluids from excessive vomiting and diarrhea, inadequate fluid intake, extensive burns, or the loss of fluid into interstitial spaces. So there is uh, something we call third spacing. It's not something that we really do in EMS. Um, it is very rarely done even in the hospital setting anymore, at least around here. But what happens, you can induce third spacing or your body will naturally do it sometimes. There's a video I will try to have for Saturday if I can find it. Joe Mistovich actually explains it very well. So I'm just going to stop with that. I will try to find the video of him explaining that because he does leaps and bounds better than I ever could. But let's look at these top three for a minute. So we lose fluids from excessive vomiting and diarrhea, which no brainer, inadequate fluid intake, and extensive burns. Now, I want you to think of sweet little 86-year-old Mima who is stuck in her way, still drinks her 64 Diet Cokes a day and thinks that that's a adequate fluid intake. Is she taking fluid in? Absolutely. Or, you get like my grandparents and you drink half a glass of water to a glass of water a day. And when you ask these people, do you drink a good bit of water? Oh, yeah. How much? Oh, about half of one of these cups a day. No, absolutely not. But a lot of the times, you get this excessive vomiting and diarrhea. And I don't mean for 6 or 7 hours. This is a buildup. You lose the volume. And, when we're sick like that, we're usually not able to replace the volume because every time we try, we expel it back out of one of the orifices of our body. So this is the cycle of hemorrhagic shock. So trauma, you get the loss of blood, you get the decrease in delivery of oxygen. Your baroreceptors trigger a hormone release. The sympathetic nervous system stimulates the increase in cardiac output, your blood pressure and perfusion. Well, eventually that goes to shit. Heart rate and contractility increase. The vessels constrict. Your respiratory rate increases again, trying to bring in more oxygen to bond with the red blood cells that are there. Your patient will exhibit tachycardia, weak peripheral pulses, decreased mental status, tachypnea, so fast breathing, pale, cool, and clammy skin. They continue to bleed out for whatever reason because people are assholes and they don't, hey, this person's trying here, but my body's just not cooperating. So then we continue to bleed, and then the brain becomes ischemic, and the medulla fails, causing a severe drop in perfusion and blood pressure. Patient becomes unresponsive, and we go, oh shit, now we got to do more. Heart rate severely increases, then the blood then drops dramatically, then the blood pressure decreases significantly. or may not be obtainable. Those are usually the fun ones. Respirations decrease and become inadequate. And then you get more blood loss and more loss of perfusion. And then everything starts to die. And then your patient dies. It's the circle of life. Now, here comes us, the ALS providers. We never get there before the trauma happens. We're always after. And I don't mean like here. We're usually down in here somewhere. Usually, I would say around these two stages. I don't have the best of luck. I carry the black cloud of EMS. So usually my patients are already, just complete shit at this point. This is where we need to put our thinking cap on and figure out how did our patient get like this? So, hey, we need to plug this bleed. We need to stop this bleed. What do we need to do to stop this bleed? We need to apply direct pressure. We need to apply a tourniquet. And I swear to God, as my witness, if any of you ever are seen by me trying to put a tourniquet on before you do direct pressure, I'm smacking you with a tourniquet. Because I have seen it more often than not. People are like, oh man, yes, we get to put a tourniquet on. But they don't do anything about the act of bleeding, even putting a damn gloved hand over it for a minute. Why they get the tourniquet out of the package? Because they're so afraid somebody else is going to put this tourniquet on. Who gives a shit? I promise you, and in all uncertainty, you're going to learn that you would rather have less blood on you and in your ambulance than you would to have the desire to put the tourniquet on. Now, the other thing that we do, and the other thing that I see, is we hurry up and we try to stick the biggest needle we can into this patient because we got to give TXA. All time favorite. All time favorite. For those of you that have worked at EMT, we're talking about a night shift person. He is not the most intelligent by any means. He went to put a tourniquet on one time. He had a 5x9 sitting over a gunshot wound to the thigh. Put the tourniquet on. Didn't pull it tight, just put it on, put the Velcro on, twisted the hell out of it. It's still wiggling and jiggling. But he thinks he's got it on. Has an IV, running fluid, was fiddling around with a TXA. His patient is profusely bleeding. Still. And he's sitting there and he's staring at him. And I get there because I was fly medic. I picked up an overtime shift. And I said, hey, I think we should probably do something about this bleeding before we worry about anything else. He goes, man, I got a tourniquet on. I got the 5x9 laying there. I said, well, does 5x9 have pressure? Um, no. Okay, maybe you should put pressure on it. Okay. And then I look down and we start to the hospital and I see the tourniquet moving. I said, did you tighten the tourniquet? Oh, yeah, man, I spun the hell out of it. Did you pull it tight? No. Okay. So we get the tourniquet on right. We pressure dressing the leg. He goes, man, this TXA ain't working. Why ain't it working? I said, well, your clotting factor wash out of your patient. Again, knowing what skills to do is great, but knowing what order to do them in is key. But hemorrhagic shock is due to a loss of blood volume, which leads to decreased cardiac output, decreased blood pressure, a sympathetic nervous slash anti. Oh, Jesus, hang on. Ugh, excuse me. Leads to. I can get through this without sneezing again. Your sympathetic, nervous, and your angiotensin systems are activated. Your angiotensin system prevents further fluid loss and causes vasoconstriction. Hang on a second. 1 second. Hang on. Everybody, take like a 5 minute break, real quick. Okay. Sorry. My little terrorists are home now, so I had to get them situated. Oh, let's see back. Okay. We did that slide. So, again, hemorrhagic shock is due to the loss of blood volume. Once we get to a certain stage, again, our body's trying to compensate. So remember this. We get anxious, we get diaphoretic, so we get sweaty. The peripheral Jesus God, vasoconstriction decreases circulation to the skin, which is why we become pale, cool. You get a weak, thready peripheral pulse, and your blood pressure remains normal as long as there's still significant fluid loss not going on. So as long as we're maintaining. So, this just never mind. There are four progressive classifications of hemorrhage. So you got class one, class two, class three, class four. Don't worry. If anybody freaks out, we'll go back to this. But so your blood volume loss in a 70-kilogram adult patient. Now, 70 kilograms. Let's stop and think about this for a moment. Kilograms to pounds. We multiply our kilograms by 2.2, right? So roughly 150, 154 pound patient, right in there. But when we talk class one hemorrhage, it's up to 15%, which is roughly 750 mLs. So a bag and a half of fluid. It's usually well tolerated, can lead to mild tachycardia. Class two is 15 to 30%, so 750 to 1500 mLs. Moderate tachycardia, pale skin, delayed cap refill. Your class three is 30 to 40, which is 1500 to 2000. Tachycardia, failure to compensate, hypotension. And then we get this lovely 40 to 50%. So the 2000 to 2500 mLs. Profound hypotension. You're not normally getting a blood pressure at this point. You're getting organ failure, you're getting bradycardia, and honestly, you're getting death. Once you lose so much blood, you're not getting any perfusion in your body. But those are the progressive classifications of shock. You have three physiological phases of shock: compensated, decompensated, and irreversible. So, compensated, we're doing okay. Decompensated, we're doing the downhill trend. Not saying we can't turn it around, but then we get to irreversible, you're done. When you get to irreversible shock, that is death. We want to try to put the roadblocks up and stop everything from getting to that point. Now, there's three tissue phases of shock: ischemic, stagnant, and washout. None of them are really good. But, so when we talk compensated shock, we get anxiety. Why do we get anxiety? Our body is releasing epinephrine from the sympathetic nervous system, which is triggering our fight or flight. We're fighting or we're running. Your blood pressure is roughly staying normal or close to. That's because you have the peripheral vasoconstriction and it shunts blood away from the capillary beds to our organs, and that increases your PVR, your peripheral vascular resistance. Your heart rate increases to maintain cardiac output. We look at tachycardia, which is between 100 to 120. 1 second. What? I don't care. You're supposed to go sit in your room. You was bad. Close the door. Well, go finish your dinner. I think I'm gonna. 1 second, guys. Sorry, children. Anyway, tachycardia. So 100 to 120. So the physiological explanation for this is decreased stimulation of the baroreceptors, which results in an increased heart rate because of our sympathetic nervous system, and it's usually stimulated from the SA node. Your pulse quality becomes weak in the extremities, and this is because the vasoconstriction that our body is doing to keep perfusing our organs and to keep oxygenating everything is shunting blood away from our extremities. It is creating a detour to all of the important areas of the body. So our respiratory rate will increase, and this is an increased stimulation of our respiratory center, which is our medulla oblongata, which is a which is a response due to the increased PaCO2 and the decrease of PaO2. And then you get pale, cool, diaphoretic skin. Why? Because the vasoconstriction is shunting everything away from the extremities. Now we get into decompensated shock. We're getting altered mental status because we're getting less oxygenated blood to our brain. We have hypotension because our blood loss is exceeding the ability of our compensation mechanisms that we have, which is usually greater than roughly 30% blood loss. We're usually greater than 120 for a heart rate. At 140 and above, our patient's circumstances are dire and may progress to bradycardia. If you ever have a shocky type patient, and you get there, and that heart rate's like 130 to 150, and now you see it at 120, 110, 100, your patient's dying, and they're going to code pretty quickly. And your pulses are pretty much becoming absent, especially peripheral pulses. Your carotid and your femoral are going to become very weak, and it's because we're not getting a sufficient cardiac output. We're even not adequately perfusing the organs. So you get what they call the air hunger stage, and that is where we're breathing greater than 30 times a minute. And it's because we're building up acid in our body and we're hypoxic. So as we build up acid, our body tries to breathe faster to breathe it all off. And then your skin's gonna become white, like ghost white, waxy and cold, and that's because you have lost your peripheral perfusion. You have decreased heart production due to inadequate metabolism. So, when we talk about the pathophysiological signs of shock, we get this thing called an ischemic stage. So, the peripheral tissues do not receive adequate perfusion. Um, if we get the perfusion restored quickly, our shock is reversible. But if the shock is not corrected and we have the lack of energy and we have a decreased pH, and it causes our precapillary sphincters to fail. So, as we know, ischemic means tissue death, or ischemia, I should say, means tissue death. So, we get that because we're not adequately getting oxygen enriched blood to the tissues. Then we get what's called our stagnation phase. This is where we're getting blood cells clumped together. Now, blood cells clump together and they're stagnant, so they're not adequately moving throughout the body. So they're not picking up oxygen. They're pretty much useless at this point. And then we get our washout phase. And this is just wreaking more havoc on the body. It leads to more tissue and organ damage. And usually at this washout phase, this is also called death. So again, all of this is more or less what we just went over. Feel free to go back and take your notes off of this or whatever. Um, but when we get to this stagnant phase, its shock is usually irreversible at this point. This phase, this washout phase, this is death. It's just a matter of time till it happens. But once we get to where a critical number of our cells or any organ dies, organ fails, or we get that irreversible shock, death occurs almost immediately. Or you can die hours or days later from acute respiratory distress syndrome or MODS or DIC. DIC is where your body just pretty much loses its ability to clot and you're just bleeding out. Um, Again, it's one of those things. You may get somebody to the hospital and they may be alive when you get there. Does not mean that they're going to be alive 4 hours or 4 days later. But now we have distributive shock. Distributive shock normally, both of our sympathetic and parasympathetic nervous systems control the diameter of our blood vessels. When we get this pathological state, it results in excessive vasodilation. So our container gets bigger and our blood pressure drops, which makes sense because we keep the same amount of fluid in the container, but the container is now bigger, which results in inadequate or hypoperfusion. So right here shows it best. So this is your 2 liter bottle. This is 2 liters of fluid. It is full. This is 2 liters of fluid in a 4 liter container. We're not filling this space. Now, can we fix this? This is a question I normally get asked. Depending on the cause. Now, is there much that you're going to do for this at the AEMT level? Not really. Is there much I'm going to do for this at the paramedic level? Depends on protocol. Depending on my cause of distributive shock, maybe there might be some meds we may hang. But again, it depends on a lot of things. The end all be all treatment is you need to get this patient to the hospital. Now, this is where I'm going to burst probably a couple people's bubble. I'm sure a lot of you are smart enough to figure this out, though. Now, nice normal vasculature, right? You're getting that IV right on in there. Congratulations. We get this. Now, what happens is, let's say you try to get into this vasculature. Guess what? No flash, no flash. You're through it, or it blows, or whatever happens. Distributive shock, you have a harder time getting the IV on the patient for a lot of reasons. The last thing you want to do is sit there and play and try to dig for 25 minutes. It just doesn't work well. So, anaphylactic shock is one of the causes of distributive shock. If you don't know what anaphylaxis is, during anaphylactic shock is caused by anaphylaxis, which is a severe allergic reaction. It causes swelling of the airway, it causes obstruction of the airway, causes vomiting, it can cause diarrhea. Um, I've really never had a anaphylactic patient that's vomited, but that's just me. You get widespread systemic vasodilation. You get the loss of fluid into the interstitial spaces, which is reducing your vasculature or your vascular volume. It is your body is losing the ability to get oxygenated blood throughout the body. It's no bueno. Now, septic shock. This occurs due to the combined effects of the body's aggressive response to a massive infection and effects of the pathogen itself. Septic shock is probably the most common form of shock you're going to see in a patient. We will get way more into this when we get into some medical stuff, but it is one of the more common things that you're going to see. Neurogenic shock. This is just a result of an impaired sympathetic nervous system function, and it can be caused by a lot of things. So some of your uh, distributive shock signs, so sepsis and anaphylaxis, tachycardia, diaphoresis, hypotension, um, altered mental status, septic shock, you're usually seeing a fever. Um, Neurogenic shock, you're getting blotchy, mottled skin. It's usually warm and dry. It's normal to lower heart rate despite the hypotension. So, what I want you to think is when you get that warm and dry skin, you have a normal or maybe just a slightly lower than normal heart rate, but hypotension. There's a really good chance you have neurogenic shock. So, cardiogenic shock. Cardiogenic shock is the failure of the pump itself as one of the causes. And we look at what is the cause of our pump to fail? What damaged it? So this could be physical damage of the myocardium, which reduces the ability of the heart to contract. So the function of the heart is impaired, and you'll get hypotension with that. So this is what an ischemic injury looks like to the heart. You have the loss of blood flow to the area of the heart because of an MI. So the contractile force is reduced, your stroke volume is reduced, and your cardiac output is reduced. All in all, bad situation. So the electrical conduction of our heart, what, stays normal. However, sorry, I'm responding to something for work. Okay. Now, the electrical portion of the heart stays intact and it stays the same. But you can start to see bradycardia, and that can result in decreased blood pressure. The heart does not contract frequently enough to maintain a pressure in the vascular system. Or we could see the complete opposite. We're seeing tachycardia, or with rates usually greater than 150 sometimes, and there's not enough time for ventricular filling. So we can either bump Jesus, beat too slow or too fast. So again, we'll get into those two things more when we get into cardiology. But again, if your heart beats too fast, it doesn't have enough time to get a good preload afterload cycle, and it doesn't have enough time to fill the chambers to adequately perfuse the body and pump the blood to where it needs to go. Obstructive shock, a mechanism creates obstruction to blood flow that significantly reduces cardiac output and hence perfusion pressure. Things like pulmonary embolism, cardiac tamponade, tension pneumothorax. When all these things happen, we get a poor gas exchange because it usually can't occur. Blood can't adequately flow through the lungs, pick up oxygen, drop off CO2, and continue, which usually creates a uh, hypercarbia, so increased CO2 in the body, low O2 in the body, because blood can't get past the obstruction. So when we assess for shock, in all cases, there is some indication of hypoperfusion. But we need to assess this patient. Heart rate, heart rhythm, blood pressure, blood sugar, temperature, pulse, pulse strength, skin, color, temp, condition, mentation, all of these things. In case you guys didn't know, look for hazards when you do your scene size up. I hate that they put all this shit in here. We're going to say we have one patient. So we walk up to this patient. We're determining the mechanism of injury or the nature of illness. Remember, we're trying to be able to do the one, two, three, big sick, little sick. What caused this? Is there obvious bleeding? Are they pale or mottled? Do they have a decreased level of responsiveness? Are they in respiratory distress? Are they dead? Believe me, I've seen people walk in and not realize that someone was dead or dead, dead. Dead, dead, we're not working. Dead will try to work. But what signs and symptoms do they have? Assess our ABCs. Make sure we have an open airway. Make sure we're adequately breathing. Make sure we have a perfusing, well, a blood pressure. Make sure we have a good pulse. You know, I'll continue to assess your pulses. Control any bleeding with direct pressure. If we have to breathe for, if we aren't adequately breathing, we breathe for our patients with positive pressure ventilation, BVM. Confirm our level of responsiveness, assess for focal defects or deficits, sorry. Exposures. And I don't mean like exposures as in, oh, this is on fire and it's right next to a house. I mean, expose your patient. So, congratulations. You're going to have to cut somebody's clothes. See if they have any other injuries. See where they're bleeding from. Um, Confirm your initial impression. Yeah, this patient's, you know, not doing good. Establish your priority for treatment and decide your transportation destination. Always transport to the most appropriate facility. A lot of the times you hear people say closest, most appropriate. In my case, I have a 12-minute difference between Boardman and Youngstown coming from down here. Now, it's trauma. Is it appropriate to take it to Boardman? No. So the closest, most appropriate facility is the trauma center. If it's a heart attack and I have cardiogenic shock, Boardman's not the most appropriate place. If it's a septic shock, yes, Boardman is appropriate. But I want to back up that step real quick. Establish the priorities for treatment. Start pre-planning in your head how we're going to treat this patient. What all do I need to do and in what order do I need to do it in? Always do the secondary assessment. Reassess. Patients in shock, whether it's medical or trauma, receive rapid physical examination. Assess baseline vitals, apply monitoring devices, get a medical history if you can, and head to toe physical exam. You want to assess as much as you possibly can, as quick as you can, so we can start treating the patient. Determine the likely underlying cause of shock. Try to figure out what caused the patient to be in the state. I don't mean try to figure out whether they were shot with a 9 millimeter or a 45. Figure out that they was shot, stabbed, fell, they're bleeding internally, they're septic, they're this, they're that, they're having a heart attack, whatever. I don't mean was they shot with a 9 millimeter or shot with a 45. Now, if they was stabbed, try to figure out how big the knife was by asking somebody, hey, did you see how big the blade was? It gives you an idea of what can be damaged on the inside. That's different. I also, because I had this question asked, don't mean stick something into the freaking wound and pull it out to measure it. No. But try to figure out what is going on. And you want to be the interruption in the patient's progression towards decompensation and irreversible shock. You want to be that roadblock that stops them from getting to that point. Patients who are in shock can deteriorate extremely quickly. This is one of these patients that I told you, if you want to reassess every 2 minutes, no more than every 5 minutes, but if you feel you need to reassess this patient every minute, every 2 minutes, do it. Reassess level of responsiveness, airway, breathing, oxygenation, circulation, and effects of the interventions. Every time we do a treatment, we reassess to see if it's actually working. Remember, untreated shock leads to death. No interventions progresses the deterioration and death happens. The best thing we can do for our patient is to prevent the progression and the deterioration of the patient. In the case of blood loss, simple interventions may be effective in preventing shock, keeping the patient warm, putting the patient on oxygen, Applying direct pressure. This is one of the cases, if you have a patient who's hemorrhaging, we put them on 15 liters because we want to load as much oxygen into the body and connecting with what blood cells we have left as possible. Being a good provider and seeing and being able to recognize early what is going on and performing the appropriate interventions early on to increase the risk of survival. I believe we went over all that already. So, blood goes out, your platelets are trying to form together. You then have tried to apply pressure and help the platelets form. That's why we don't remove gauze, or we don't remove our initial layer of gauze. Once it's on there, we leave it on there and we keep applying new over top of that. We're trying to help the body naturally clot. So, squirting, pulsating, and bright red, think arteries. Steady, slow, dark red, think venous. And slow, even flow that's pretty much stopping itself, think capillary bleeding. 2 seconds while I go blow my nose. Oh, good God. So, managing bleeding and shock. We always remember what is our goal in life? It is maintaining homeostasis. Now, hemostasis. Haha. Remember, medical terminology here. Now, actually, let's back up because I didn't do my normal thing here. Okay. So, untreated shock leads to no homeostasis. So, the way that I explain this, anybody want two dogs, you can have them. Um, the way that I always try to explain this to people, because for those of you that know Frank Dispenza, Frank has been doing this so long, his original card came out on Slate. But when Frank taught my advanced class, he said our goal in EMS is to always why are we losing people? Is to help our patients maintain homeostasis. What do we need to maintain homeostasis? We need to leave the blood in the body, we need to leave the oxygen in the lungs, and we need to make sure that the blood picks up the oxygen and drops it off where it needs to go. That is what we do. 1 second again. So, our job again, we need to keep the blood inside the body and we need to keep the oxygen circulating around. Now, we get all these cool tips, tricks, and things that we're allowed to do to make sure that the blood stays inside the body and to make sure that oxygen is in the lungs and going around and around. When learning to know when to use and to do those things is what makes you a good provider. Okay, I gave my Frank spiel. Now I feel better. So, there's a better slide for this. All right. Bear with me because there is a much better slide here in a few to actually go over this. So, early on in class, I told you guys that one of the things that you need to be able to do in EMS at any level is learn patient medications. Now, I don't know about you, but my favorite thing in the world is when I ask a patient if they're on a blood thinner, they say, "Oh yeah, I'm on aspirin." Aspirin is not a blood thinner. Aspirin simply makes the blood less sticky and doesn't necessarily let the clots form to one another. Now, Eliquis, Eliquis is a blood thinner. Plavix, Plavix is a blood thinner. Um, so we have these meds. Come on. Um, and there's some natural things that people take that also may make them bleed more, like fish oil. It can reduce blood clotting, but it's not a blood thinner. Now, people that do take fish oil do tend to bleed more. I can tell you that. Um, but learning some of these things now, okay. Do I expect you to sit there and go, "Oh, ginseng, ginseng, did it?" No. But picking up on like Xarelto, Coumadin, heparin, um, Eliquis, Plavix, things like that. Those are important to stick out so that when you see this patient and they give you their medication list, you can put two and two together. And I'm not wasting your time with this because we do this in trauma. But in case you guys didn't know, you see this lovely picture? This is applying direct pressure. Please always do it wearing gloves. So I don't know why this is in here because that is in trauma. This is in trauma. I don't know if you guys have ever used this shit, but it's absolutely amazing and it works freaking wonderful. Managing bleeding and shock. Again, we're literally about to get into this in like 2 or 3 weeks. So please bear with me. I promise I'm not jipping you on an education. I'm trying to get as much education into one night as I can. All right, seeing how we're getting ready to go over all of it again, there's no sense in doing it half-assed. Okay, now managing bleeding and shock. Let's talk about this. So, how many people feel free to send it, not send it? It's up to you if you want to participate or send it in the chat. You can send it directly, not send it at all. But I want you guys to start thinking. How many people in your overall time in EMS have been on a crew and have had a trauma patient and you have watched a provider just run, and I mean run the fluid to this patient? What I want you to think about is through your time in EMS and the short time in this class and the time that you've had in the field, have you started to see or form an opinion on is that the right thing to do? And the reason I say that is, and there's more of the question to come, so hang on. But is that necessarily the right thing to do for your patient? Because what happens when we start dumping fluid into any patient? Now, it doesn't just have to be a bleeding patient. Our septic shock patients, do they need a lot of fluid? Yes. Do they need it over an amount of time? Yes. But we start dumping into it and we dilute the blood. Now, if we've learned anything thus far, what is one of the things we have an inadequate supply of when we're in shock? Oxygen. Now, if we dilute our blood, we're diluting the ability for our body's red blood cells to pick up oxygen and transport it through the body because, as we know, fluid itself does not have an oxygen carrying capability. Exactly. We lose the clotting factor, and when we lose a clotting factor, we lose everything in this patient. Now, I want you to think about, again, Mima or Peepaw, whatever you want to think of. Think of our elderly patient. We go get them at home, we go get them at the nursing home, and they are chronically sick. Like they have CHF, they have COPD, they've had UTIs, they've had this, that, the other, they have a colostomy, they have this, they just your metabolic shit show on a good day. So, this patient is septic. They're fevered, they're tachycardic, they're hypotensive. You decide that you want to dump fluid into this patient because so TXA helps with um let me rephrase this. So TXA helps in the clotting factor of the body. So your body's natural clotting factor still has to be working in order for TXA to truly work. Um, you can see minimal side effects of it if you start to lose that clotting factor, but a lot of the times, one of the reasons they want us to give it, and at least it used to be, they want you to give it within an hour of injury or onset. And it's because usually, depending on the severity, obviously if you got someone that's got a damn arterial bleed, they don't have an hour. But if you can get there and you can see that your patient's lost 1,000 or 1,500 mLs, and we're going to intervene, there still may be a clotting factor there. That is why, again, we're big on direct pressure prior to an IV or TXA administration. But we do the direct pressure, we do the tourniquet, even if we have to have our partner take over direct pressure after the tourniquet's on, so we can get the IV, so we can administer the TXA, that's fine. Do we still want to give this patient some level of fluid? Yes. Do we want to do it 250 mLs at a time? Absolutely. And that's my golden rule. Any patient that I give fluid to, with the exception of pediatrics, I give 250 mLs at a time and I reassess. I reassess vitals, I reassess lung sounds. If it's a trauma patient, I look at the wound. Is it starting to bleed more? If I'm starting to bleed more, I'm backing that fluid off. But, you know, when we look at this, so, IV fluids during transport. Let's start thinking about this. And this is where I tell you guys, you got to put your critical thinking hat on. I know I got two RNs in this class. I think only one of you are on tonight. But especially my RNs in this group can tell you, even in the hospital, 99.9% of the time, fluids are given via a pump, and it's given over a period of time. Now, can we bolus fluids into a patient? Yes. And this is often the debate that I have with people is, well, when you go to the hospital, you always see fluids running on somebody. Correct. But at what time frame are they running on somebody? So let's start to critically think about what are some of the things that's going to happen to this patient while we're running IV fluids on them. You get the blood dilution, your oncotic pressure drops, you lose your clotting factor, You may get an artificial increase in blood pressure depending on, and I call it an artificial increase because it's not blood volume increasing the blood pressure. It is water, more or less, that doesn't have an oxygen carrying capability. It doesn't have a clotting factor. And what you need to remember is we can increase acidosis because ringers and normal saline are more acidic than the body itself. And IV fluids are never at body temperature, they're at room temperature. And I don't know about you, but I don't keep my ambulance bay at 98.6 degrees Fahrenheit. Now, can you put your fluids on a warmer? Absolutely. Do they stay warm the entire time? No. Can you bust some heat packs and wrap them around there? Absolutely. Those of you that have worked with me, I know you've seen me do it before. But do we still induce hypothermia in these patients? Absolutely, freaking lutely. I want you to think, for those of us that are on a volunteer department, tones go off at 2 o'clock in the morning. It's 2 degrees outside. You get on scene and you're on scene for 45 minutes. You have 2 bags of fluid on the warmer. They're 500 ml bags. You have a 40-minute transport time and stats not flying. You get that bag of fluid out off of the warmer, spike your bag, prime your drip set. You have it hanging. You miss your first IV, you get your second IV, you get your flush and lock on there. Your flush surely in the hell wasn't on the IV warmer, so it's at whatever temperature the cab of the truck is. Or the, I should, not the cab, the patient care compartment of the truck is. And now your fluids have started to lose their heat too. How much good are we truly doing by hanging fluids on every patient? So, at what point do we really need to give them? Well, we need to look at several things when we're doing this. And I don't just mean with our hypovolemic patients, I mean all patients. Do we have a perfusing pressure? Are we maintaining a perfusing pressure? So, do we have a map, a mean arterial pressure of 65? For those of you that don't want to do the math to figure that out, your cardiac monitor already figures it out for you. It's a little number that's in parentheses next to your blood pressure. 65 is a nice ideal number to tell you that your body is still adequately perfusing. Once we start to dip below that, start looking at fluid administration. But already have your IV and everything in place before we take those fluids off the warmer. Let's start to look at, do we think our patient is acidotic? Do we really want to, are we going to increase it that much? No. But is there a benefit of giving fluid? And then what I want you to think of, do the benefits or the rewards outweigh the risk? Now, I'm not trying to scare you to tell you to never give a patient fluid, but I want you to stop and think. A lot of people are like, "Oh, it's just fluid. It's nothing. It's not a drug." Fluid is a drug. It absolutely is a drug. And we need to know when to give it and why to give it, but we also need to know when not to give it, why we're not giving it. And then you need to be able to justify yourself when you get to the ER and when you do your report. So, a good foundation or a good solid assessment builds the foundation of your treatment plan. Just remember that. So, there is no way that we will control internal bleeding in the pre-hospital setting. Now, this lovely word, these two lovely words right here, this is on registry. It'll be on exams in here. It'll be on Brady Lab. It will be brought up. Permissive hypotension. What we are trying to do is maintain a systolic blood pressure of roughly 80 to 90. Now, what's our other options? Let's look at the mean arterial pressure. If we have a map of roughly 65, we're still adequately perfusing. Do we need to keep assessing mental status and everything else? Yes. Now, how do we maintain this? I say 250 at a time and reassess. This says 500 at a time. Are you going to hurt somebody with 500 cc's of fluid? No. But so 250 to 500 and reassess. So if we have a head injury and we have a suspected increased intracranial pressure and hemorrhagic shock, your systolic or goal is about 90 to 100. We don't necessarily, and actually, when we get into trauma, something tells me there's a slide that actually says 80 to 90 as well. Um, Registry purposes, 80 to 90 is your golden number. Um, because when we talk increased intracranial pressure, we do not want to keep dumping fluid and increasing that. So now that we got the roles of TXA there, okay. Boom. So TXA, transischemic acid. It preserves the framework of existing clot structure and it prevents the clot breakdown. So again, um, this is all protocol dependent. So if you don't have UH, don't necessarily pay attention to this. But this is some of the reasons that we do give TXA evidence of a current or previous uncontrolled hemorrhage, hemorrhagic shock from recent trauma, less than 1 hour, sustained tachycardia of 120 or greater, and or hypotension of less than 90. TXA must be given within 60 minutes of the time of injury. Postpartum hemorrhage with signs of shock. What are our contraindications? They're allergic to it. Suspected CVA, MI, or PE. Now, if you have a semi-unresponsive patient or an altered patient, they may not be able to tell you if they're allergic. Now, if the benefit outweighs the risk, you give it. You can always treat for the anaphylactic reaction that may come along with it. But you do not want to necessarily administer this in a non-hemorrhagic shock patient. Now, I don't necessarily mean that you do not give TXA in a non-hemorrhagic shock patient. If you have a septic shock patient, they do not get TXA. If you have a cardiogenic shock patient, they do not get TXA. So again, side effects can be anaphylaxis, thrombus, hypotension with rapid infusion. If you infuse it faster than 100 milligrams a minute, and we're going to get into that here in just a second. So you can get nausea, vomiting, diarrhea. You can get visual disturbances. However, we give TXA technically two different types of doses, but for the all intensive purposes, for hemorrhagic shock, you're giving 2 grams over 10 minutes. So that's 2,000 milligrams. We're going to mix it in 100 mLs of D5 or normal saline, and we're going to give it over 10 minutes. So if you're using a 10 drop set, you give 2 drops a second. If you're giving through a 15 drop, you give 3 drops a second. Now, if you have like a bleeding tooth socket that won't stop or a severe nosebleed that won't stop, you can soak gauze with TXA. It doesn't need to be a set amount inserted into the nostril or into the gum socket. Um, Pediatric dose is 15 milligrams per kilogram. If they're younger than 16, call MedCom. Are they going to tell you to give it? That's going to be situational dependent. Um, so remember, TXA doesn't create new clots. It helps preserve the clots that are there, and it helps them from being further broke down. So when we talk fluid resuscitation and a non-hemorrhagic shock, non-hemorrhagic shock is best treated by reversing the underlying cause. We want to try to know the pathophysiology of the various types of shock. Um, Septic and anaphylactic shock have distributive and hypovolemic components. Uh, Now, when we talk anaphylaxis, now we get into this later, so you're getting the condensed version of it. But when we talk anaphylaxis, so we have anaphylactic shock. When we give the epinephrine, that causes vasoconstriction, which helps fix the vasodilation that it was causing. Um, Fluids in this case are not the life-saving treatment. Realizing that your patient's in anaphylactic shock and giving the epinephrine to cause the vasoconstriction is the life-saving treatment there. So, in septic shock, patients may be dehydrated from the underlying infection. Um, in cardiogenic shock, patients may not be able to handle any additional fluid load without developing pulmonary edema. Excuse me. Again, this is where assessing and reassessing our patient is key. In obstructive shock, fluids can increase our preload and increase cardiac output and blood pressure, but it does not resolve the obstruction. So the again, the artificialness is only temporary. And I call it artificialness because fluids are like, you know, putting a blind over a hole in the wall. It only temporarily fixes the problem. The problem doesn't go away. Um, Neurogenic shock is not always, but it's usually temporary. Often peripheral perfusion is still intact despite the hypotension, and always follow your protocol for fluid therapy goals. So, before we get into this, because you guys are going to come through the computer and kill me, um, blah, blah, blah. It is 7:42. Let's take a 10-minute break real quick. So let's be back at 7:52, 7:53, and we're gonna dive into the cardiac arrest part of this, and we'll see who tries to kill me first. Okay, let's get the show on the road in 2 seconds here. Do, 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 All right, so let's talk cardiac arrest. So, in case you did not know, um, this is where your heart is no longer beating. And I'm a smartass when I say that, and I apologize. Um, hang on. God dang it. I don't want this up here yet. Because I literally had a student, and this will show you the stupidity of people that go into EMS. I literally had a student one time tell me or ask me, "What does cardiac arrest mean?" I said, "Like, are you being serious?" And they said, "Yes." So, what I'm going to do, oh, actually, I'm going to do this. Okay. All right. So, I believe everybody in this class we have determined has UH protocol. So, to break this lovely crap down, let me see. All right. So, cardiac arrest. Forget this BLS crap that's up here because we're going to dive into all this. So, due to uneducated people in this world and in this profession, and because EMS is not actually viewed as what it truly is, we have to now we have to look at our DOA guidelines and contact medical control to pronounce somebody as dead before we even decide to work them or not work them. If they have a DNR, contact medical control. I have a 76-year-old male patient found pulseless apneic, has a signed DNR present looking for a time of death because we are not allowed to pronounce. Now, however, we get there, we determine we're going to work this cardiac arrest. And then you probably will hear me somewhere in the background go, let's go to work. Cardiac arrests are not fun. I don't care who you are. But any Hoosers, CPR immediately. Now, not this next skills day, like not this Saturday, but the following Saturday, we're going to simulate cardiac arrest. However, I'm going to warn you, we're going to run it and run it and run it again. Because I will stress this again. We start CPR immediately. Why do I say it like that? Because we have these confangled Lucas devices on the truck. And people think that this is the end all be all do all fixes all thing. We have to get it on them right now. In all reality, good old fashioned manual CPR for 2 minutes per round is fabulous. And if I have a workable arrest, there is times we're doing manual CPR over putting that Lucas on somebody. When I go to transport, I'll put a Lucas on somebody. But we start our CPR immediately before we do anything else. Um, we put the patient on the cardiac monitor, the defibrillator, the AED, whatever, as soon as it's available. Now, congratulations. You have been bestowed ALS. You now get to read the monitor and use a manual defib mode. Congratulations. We're big boys and girls now. We don't operate in AED mode anymore. I'm going to tell you right now, this is my biggest freaking pet peeve when it comes to cardiac arrest. I hate AED mode because you get that do, the noise in the background. It's annoying, drives me nuts. But as an ALS provider, we need to have enough common sense to know every 2 minutes we're doing a rhythm check. We need to be competent enough to know when we look at that monitor, that's asystole, that's PEA, that's VFib, that's VTAC, that's torsades. Technically, you're not supposed to know torsades. When you leave my class, you'll know torsades. However, so we attach the monitor, we see that it's whatever rhythm. In our mind, we go to the appropriate protocol. Now, please, ready for this? We don't break out the protocol book. We use our minds. We are smart enough to know that we do ABC, one, two, three. But deliver a shock if shockable. Immediately back on the chest for 2 minutes. Now we get our IV or our IO. As we're doing all of this, usually there's two or three or four or five or 26 people because for whatever reason, everybody feels the need to come and stand around on a cardiac arrest. Again, another reason that I hate them because I feel like an asshole for these families because they see all these people standing around not doing anything and they think that we should be doing more. So we send somebody to go get a medical history. We try to figure out is this a dialysis patient or what kind of medical history they have. But if you have a dialysis patient that's in asystole, VFib, or pulseless VTAC, we need to know. But anyway, so CPR, attach the monitor, deliver a shock if it's shockable, immediately back on the chest. Then we get our IV or IO. In the whole meantime, please be bagging your patient. Then we go into inserting an advanced airway. At this point, we should be getting close to or already done our rhythm check. If it's workable, cool, we're still going. If it's a shockable rhythm, we're going to shock again. We're going to maintain CPR unless the patient gets a pulse back and they look at us. Woohoo. But we're going to maintain our CPR and our airway. You are adults now. We do not follow AED prompts. We are big girls and boys, and we put our big girl and boy panties on before we went and worked this arrest. We have our monitor in manual mode. Just because you are ALS does not mean that you do not need a paramedic. If you don't have one coming, you should probably be getting one. So, patients in cardiac arrest should be worked on scene unless special resuscitation circumstances exist that would benefit from hospital treatment unavailable in the field. If you cannot give cardiac drugs, we really should be trying to do all the interventions we can and then transporting. However, if we decide that it's not safe to extricate this patient, we don't have enough hands or whatever, or we're going to have to interrupt CPR longer than necessary if we don't have a Lucas device, we do this lovely thing called field termination. Arrest that is not witnessed by EMS or first responders, and no ROSC has been obtained after 20 minutes of CPR, and we have had a non-shockable rhythm. At any point we shock this patient, we should be transporting. Now, if you're ALS, arrest not witnessed by EMS or first responders, an advanced airway, so whether that's an endotracheal tube, a king, an IGEL, whatever is in place. Vascular or IO access is in place. Continuous CPR. At least 2 rounds of ACLS medication for you as ACLS or ALS to terminate it, which means you need a paramedic. Asystole confirmed in 2 leads or bradycardic wide complex PEA. We will learn what that is when we do EKG recognition. You've done 20 minutes of resuscitation. You have a intra-arrest capnography reading of 10 or less. That indicates there is no perfusion and may be helpful in considering termination efforts. But now let's say you can't do all these things to terminate. Once you get past this part right here, this airway protocol, you got your IVIO, you got your airway. We need to really start looking at packaging and transportation of this patient. Now, I'm going to go over this again. We get there. They're dead. Pulseless, apneic, warm, workable. Pupils are not fixed, not dilated. We're going to start CPR. They do not have a DNR. We start CPR. Put the monitor on them. Manual. We switch it to pads mode. Manually interpret the rhythm, please. Shock them if necessary. Get right back on the chest. We immediately get on the chest with manual CPR before we ever put the Lucas device on the patient. I cannot stress this enough. And I'm going to tell you, yes, I have read the studies that are out there that says, oh, manual CPR is better because it is. Because we don't take the time to do manual CPR before we put the Lucas device on the patient. So, cardiac arrest is SCA. ACS is acute coronary syndrome. Cardiac arrest is caused by dysrhythmias, acute coronary syndrome, trauma, hypothermia, drug overdose, an electrolyte imbalance, toxins, stroke, pulmonary embolism. It is rare in children, but usually is a result of respiratory failure. I'm going to tell you right now, one of the big reasons that I hate being a paramedic is pediatric arrests. I have worked more in my career than I think any provider ever should have. And it does take a toll. But I will tell you, it's just like working an adult. You do what you got to do. So if you ever are the primary person till a paramedic gets there, you ever decide you hate your life enough that you want to become a paramedic, and you ever get a pediatric arrest, take the kid factor out of it. Take the fact that you have kids at home out of it. Take everything out of it and leave that all on the sidelines. Because a distracted provider is a deadly provider. We have to be able to put that blanket up, put that wall up, and do our job. Now, let's see what the okay, here we go. So, when our heart develops a dysrhythmia, so AFib, AFib RVR, VTAC, VFib, torsades, junctionals, whatever, the 27,000 rhythms that are out there. But it does not produce a mechanical contraction sufficient enough to generate cardiac output. So when we go into a dysrhythmia, and it's a lethal arrhythmia, or lethal dysrhythmia, I should say, because arrhythmia is without beat. Anyway, when we go into this dysrhythmia, and it's fatal or it's lethal, so, our patient goes into AFib. Is AFib going to cause them to go to cardiac arrest right away? No. But is the heart going to quiver, quiver, shake, shake, quiver, quiver, shake, shake, and possibly produce a clot and throw it? Yup. Are we going to possibly stroke out from that? Yup. Can that cause us to go to cardiac arrest? Yup. So do we need to maybe fix that or have the hospital fix that? Yup. But when our heart doesn't beat, perfusion ceases. If perfusion ceases, the patient becomes also pulseless. See, it's a two-way street. We don't perfuse without a heartbeat, and if we don't perfuse enough, the heart stops beating. So if we have inadequate perfusion to a certain point, or our perfusion stops, our patient becomes pulseless, unresponsive, and apneic. So our pulseless rhythms are VFib, VTAC, asystole, and pulseless electrical activity. Pulseless electrical activity is a slow, wide, complex rhythm. And a lot of people sometimes will think that they got ROSC and the patient's just bradycardic, and they're not. Um, they're all workable rhythms, though. I mean, I've worked patients out of asystole into VFib into VTach back to a pulse. You know, I mean, I've and they walked out of the hospital, and I've had patients code in front of me that went to the morgue. Um, just you never know how an arrest is going to go because when it's somebody's time, it's somebody's time. So we're going to get into this more when we do EKG recognition, but here's the gist of it. VFib, chaotic electrical discharges, asystole, pretty much flatline. VTach. Um, Make sure they don't have a pulse with this because you can have pulse producing VTach. We'll again get into that cardiology. But in a cardiac arrest, body tissues and organ systems rapidly are damaged by the lack of perfusion. Every second that a cell or an organ does not have oxygen-enriched blood delivered to it is a second that it's becoming ischemic and it's dying. The brain and the heart are extremely sensitive to ischemia. Cellular death occurs in 4 to 6 minutes, death in 8 to 10 minutes if perfusion is not restored. If I blow my nose before you guys can't understand me. This infection is going to be the death of me. If you have a patient that bleeds out or is bleeding out, they're probably going to go into cardiac arrest. If they bleed out, they're definitely going to cardiac arrest. And a lot of the times, you're not getting those patients back. And that is why, I will cover this in trauma. Um, I am a big believer, um, and we need to be pickier about the cardiac arrests that we work and transport. I've worked alongside medics that transport 95% of their cardiac arrests. Why, I don't know. Um, I will tell you, if I had to put a number to it, I bet you 10% or less of my cardiac arrests ever get transported. And I'm going to tell you why. So I've done this long enough that the it the acceptance becomes easier with the family when we don't instill false hope. That is why one of my big things that I always tell people is we will always say we're doing everything that we can. We're doing everything that they would do in the emergency room. And, if I have a really good crew there and all I'm there to do is push meds, um, and I can slip away for 3 or 4 minutes and go explain to the loved ones what we're doing, I will. But I never tell them we're going to get them back. You never say it's looking good. We always say we're doing everything we can. We're going to do everything we can. We're doing everything that they would do in an emergency room. That's why we're still here. And for some reason, the probably hundreds of arrests that I have worked at this point, um, I mean, hell, we was probably working. I mean, the people that's in this class from EMT will tell you, even in our AMR days, it was nothing to work 20, 25 arrests a month. I mean, and especially on nights, shit, we was probably working sometimes, you get one every other day, or there's weekends we'd work seven at a time. Um, and hey, I'm going to tell you guys, so we'll go back to the well-being of us chapter. At some point, it also takes a toll on you because it also instills a false hope in providers when we prematurely transport a patient. And then you know, um, it also puts this greater workload on our hospital system and on our nurses and on our doctors that probably 95% of the time isn't needed. So now we take them to the hospital. They pronounce them dead. Now they got to lay there and take up a room until they get to the morgue. We just took easy 3 to 4 nurses, a doctor, a resident out of rotation because now they're in the room with this patient, and there's 30 to 40 to 50 other patients that they have to deal with. Or, well, and not or, but and now the family gets this false hope, and now they have to have their meltdown at the hospital in front of everybody. So we do our damnedest on scene and only transport if it's necessary. And that is why we follow this chain of survival. Immediate recognition and activate 911. Well, we are 911, so we're not doing that stage, but early and high quality CPR. So I will tell you that 98% of the time, even if someone says, hey, they're a DNR, I will have someone start CPR until the DNR is in my hand. Because word of mouth, oh, they wouldn't want anything done, is only good if the doctor says, yes, you can accept that. So early on the chest, good CPR. I like 100 to 120 minute. I like 120 a minute. Um, Rapid defibrillation, that's why we're on the chest right away. We're putting the pads on right away. We're recognizing the rhythm right away. We're shocking right away. We're trying to shock them out of that lethal arrhythmia or dysrhythmia. Sorry. Advanced resuscitation by EMS and other care providers. Again, first and foremost, CPR, BVM ventilations, defibrillation, IVIO, airway. Every one of my arrests. Now, it's a little bit different because you guys can't give the cardiac drugs, but I'll tell you, every one of my arrests follows the same pattern. CPR, well, first of all, confirmation of no pulse, no breathing. CPR on the chest, like good CPR on the chest. We're banging out 120 minute BVM ventilations and being put on the monitor at the same time. Confirmation of rhythm, defibrillation if it's an appropriate rhythm to shock. We do 2 minutes of that, all of that. Rhythm check, shock again if it's necessary. IV or IO, whatever's going on. Get that, meds, airway, every time. You're also less likely to miss a step doing it the same way every time, but every time that's how the arrest works. So we get our early high quality CPR, rapid defib, advanced resuscitation by EMS, post arrest care if we get ROSC, cardiac cath if it's appropriate at the hospital, and an ICU, and then recovery. Probably 1% of cardiac arrests truly walk out of the hospital, especially in our area. Um, I will tell you, I have taken many arrests to St. E's, Youngstown, and time they call a cath lab team in and they do this and oh we're so busy we do that and oh well hey oh hey ooh, oh, why'd you bring them here and we go through all that with Yaz. Then they finally start getting cardiac care. It's hours later. I will tell you, I was fortunate when I went to medic school. I did all my clinicals except for a couple hours at UH when I did hospital time. I've had the privilege of going into other hospitals working EMS. I've been into UPMC, I've been into AGH, I've been into Heritage Valley Beaver, and it seems like every other hospital system just does the cardiac care better. I've been into Altman, all of them, and I will tell you, if you go to Youngstown, Godspeed, because you nor your patient get the recognition or respect that you deserve. Um, so lay rescuer, so the dispatch is given the instruction to the lay person. They're taught unresponsive patients with absolute absent or abnormal breathing requires immediate CPR. Um, a lot of the times, Joe Blow public isn't able to distinguish between who has a pulse and who doesn't. So that's why they immediately just have them get on the chest. And I'll even tell you this one. Healthcare providers sometimes can't even tell if there's a freaking pulse or not. You ever go to some of these nursing homes? Jesus. But we quickly check the patient's carotid pulse. If the pulse is not detected within 10 seconds, begin chest compressions. Um, again, it's why you normally have two people on an ambulance, uh, or you get the damn clown car of 26 people coming. It drives me nuts. But when we check for a pulse, we need to do look, listen, feel. So fingers on the carotid, ear down by the mouth, looking at the chest. No more than 10 seconds. See, bada bing, bada boom. We use our two fingers. Don't use your thumb. Oh, we do a scene size up. Haha. Unresponsive patient. I think big sick. They can be cyanotic or have mottled skin. And there's an immediate need to resuscitate. Now, again, I'm picky about what cardiac arrests I work. A lot of paramedics will tell you they're picky about what cardiac arrests they work. If you have a downtime of greater than 20 minutes, pupils are fixed and dilated, a lot of the times we're not getting them back. We're beating the shit out of a corpse for no reason. We're giving false hope to a family for no reason. Now, I will tell you, I went out past where people were playing banjos with their toes for an arrest one night. Got there, the patient should have never have been worked. One of the family members was an RN, started CPR, was giving mouth to trach ventilations with coffee ground emesis that had spewed out all over the place, which was enough for me. Um, yeah, poor Marissa was there for this one. But he had been down for so long. EMT Carrollton shows up and immediately tells family, oh, he's got a good chance. They're going to win. No, absolutely not. He's dead. Plus, he had end stage cancer. Um, but I mean, downtime was like 35, 40 minutes before I got there. I would never work that. The scene turned hostile. Like we should have dropped our shit and left because the brother's threatening to shoot us all, threatening to get a gun. It was just a bad day to be John. Let me tell you. But it's why I'm picky about what arrests I work. And as you become, your own ALS provider and you find your own way, you're going to be picky about what arrest you start to work and what type of treatments you do just in general. But um cardiac arrest may not be immediately apparent to some people. Um, oh God, that poor drug box is never the same. It's still in the garage. But my favorite is sometimes you'll get dispatched. Male patient had a seizure. Code two, so no lights, no sirens. Male patient had a seizure, is on the ground, not seizing anymore, and you get there and they're cardiac arrest because it was the VFib shake. But again, we immediately check for responsiveness, breathing, pulse. We, if they're unresponsive and has no breathing or agonal respirations, we're already checking a pulse at that point. Start CPR. Make sure that it's workable. Make sure that you're not doing chest compressions on a decomposing body. Um, oh well, I wonder how his glasses got there. But he did get the. Oh no, screen's open on the fireplace. There's gonna be a structure fire too. That's just a bad scenario. Scene's not safe. So once the arrest is recognized, compressions are started, and um, cardiac arrest is identified with circulation, airway, breathing, so CAB. Um, we keep going back and forth. Airway, breathing, circulation, CAB, BAC, ABC, 123, ZAZ, whatever. Again, we check, yeah, or the patient covered in bed. No, no, ain't working that one either. Um, so here, I'll give you an example. Granted, the scene is technically safe, but oh no, no. So, working EMT in Youngstown, get called for an unresponsive male patient. Don't get me wrong, he was dead. I was justified in pronouncing. I didn't even put him on the cardiac monitor. We walked into this house and I noticed there was plastic on everything, and that should have been clue one being in Youngstown. But I walk into the bedroom and something had fallen on my shoulder, and I brushed it off and I looked, and there was freaking bugs on the wall, on the ceiling, everywhere. And as we took another step in, there was crunching. Absolutely not. We was out. No, ain't working in that either. So that scene, definitely no. But I will tell you, and some providers may argue that I am wrong when I tell you this. I don't care if you go CAB or ABC. I assess all three at the same time if I have an unresponsive patient. I'm checking for a pulse, checking airway, checking breathing at the same time. You know, you can put one head under the neck, raise up a little bit. You get two fingers feeling for a pulse, your ear by their mouth to see if they're breathing, and you're looking for chest rise and fall. And when you come back up, you can look and see if there's anything in the airway. But that's how I do it. It cuts time, you know. Then we start the care that we have to do. So we know chest compressions with the BVM is 30 to 2. When we have an airway in place, it's one breath every 6 seconds or targeted ventilation, depending on our CO2 level, with continuous compressions. So there is a certain amount of oxygen that's in our blood and lungs, but an ideal amount is not being circulated. That is why we're on the chest right away doing compressions first. So the time that it takes to assess, establish an airway, and then perform BVM ventilations delays the circulation of the blood. I will tell you, there are some providers that'll tell you stop doing CPR while they're intubating the patient. I don't. Just keep doing CPR. You may stop for 2 seconds, depending on how bad the airway is, but you never stop compressions for more than 10 seconds. Um, but you have to create both a negative and a positive intrathoracic pressure to alternately fill the heart with blood and squeeze it out into circulation. And plus, we need to oxygenate the blood before it gets to the heart. So we have to do all these things, but we need to do the compressions. I always compare it to we're priming the heart. We're getting the blood going and we're adding the oxygen. So we're adding more fuel to it, let's say. So we're doing compressions, we're bagging, we're getting the oxygen in there. And the more we go, the more blood or the more oxygen we get in the body, the more blood we get circulated around. But we push hard and fast. We don't stop CPR unless we absolutely have to. When we pause for a rhythm check and a defibrillation, it's no more than 10 seconds. The way I do mine, we're doing compressions. I identify the rhythm. When we immediately start compressions again, I charge my monitor. We stop, I shock, we do CPR. You have to be smart enough to know to say, you're clear, I'm clear, we're all clear, but that's how we do it. If you're alone, you do chest compressions until another provider arrives. You know, I've been in the situation to where I'll do one-handed CPR as I get the monitor on and get the patient on the Lucas and all this other fun stuff. Again, compressions are 100 to 120 per minute. I prefer 120. It's 30 compressions to two ventilations until an advanced airway is in place, and we minimize our interruptions. Hard and fast in the center of the chest. So, if you have limited manpower, you know, these things are great. I will tell you, I've used both. I like both. Um, the auto pulse, which is on the left, it's got more advantages. You can use it as its own extrication device because down here a mat pulls out almost like a mega mover, and you just carry them all out. This band wraps around. You can put them on bigger patients. You can put them on a freaking Reeves with this thing and stand them straight up in the damn air. They're awesome. The Lucas is a good tool too. They are finding that these things do cause barotrauma, which may reduce our ROSC rate. However, you have to do what you have to do with the limited manpower that we often get. But we want to open the airway, deliver ventilations via BVM, or mouth to a barrier mask. Don't ever do mouth to mouth. Ugh. Deliver. Wow, might need a stroke assessment. Deliver each ventilation over 1 second using enough volume to obtain visual chest rise. We're not taking both hands and just squeezing every bit of air out of that BVM into them. We're not trying to pop a lung. We're not trying to overdo the tidal volume. But if we're doing BVM ventilations, the second that breath's done, back on the chest. The two breaths are done, but we're back on the chest. If air does not despite yeah, if air does not enter despite proper airway position, suspect that you have an FBAO, a foreign body airway obstruction. Treat for Fabio. The treatment for Fabio is chest compressions. Check to see if the object is dislodged. Never do a blind finger sweep. Congratulations, boys and girls. Guess what? You're ALS now. Get that laryngoscope, stick that blade in there, open it up, take your McGills, and pull some bitch on out. I'm going to tell you something. I will tell you the hardest thing you'll ever pull out of someone's airway is a marshmallow. When you pull a hot dog out, you won't eat a hot dog for at least 6 months. And if you pull out certain things, stand back as soon as you do it because there's usually a trail of vomit coming behind you. Uh-uh. No, 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 no. You pull it out slowly, and then when you get it out, you hurry up and get your face out of the way. Remember, vomiting can occur. Ensure suction is available. Advanced airways in place. Chest compressions are delivered continuously at 100 to 120 per minute, and we ventilate every 6 seconds, or we do targeted ventilation depending on what our end tidal is. End tidal will dictate how we work a cardiac arrest. So we'll get more into end tidal reading Monday. Well, I'm gonna try to hopefully have the right mannequin here Saturday so we can mess with it a little bit. Um, but if an entitle's too low or too high, it has negative outcomes. I told you guys about the patient that I had that had a initial entitle reading greater than 100 and that was alive. He wasn't alive very long. But defibrillation, we want early defibrillation. It's critical for patients in pulseless ventricular rhythm. We want to shock them out of it. The greater the interval between arrest and the start of resuscitation, the poorer the chance of survival. And to maximize successful defibrillation, keep chest compressions, interruptions to a minimum. Um, VFib, thousands of electrical foci, and the heart depolarize independently. Your myocardium quivers and cannot eject blood properly. That's why you get the erratic heart squiggles, I'll call them for now. VTAC, it appears organized. If the patient's pulseless, it's treated as the same as VFib. Shock that shit. Never apply an AED to a patient with a pulse. Follow your protocols to determine instances when CPR started or continued prior to defibrillation. Always do CPR. Hey, we don't use AEDs as ALS providers. Just keep that in mind. But if you can see that your patient's crashing, don't be afraid to put the patient on the monitor before they go into cardiac arrest. Because if you catch them as soon as they go into that rhythm and you shock them, you got a better chance. So the physiology of a defib, it doesn't restart the heart. People are like, "Oh my God, you're jump starting the heart." No, the the electrical current that is it's passed through the heart, the depolarizes the cardiac electrical cells to stop them from working independently of the cardiac conduction system. And manual defibrillation requires training that you guys will get. Um, but what we're trying to do when we shock the patient is we want the cardiac Jesus, the electrical pathway to flow through the heart and back through. And what we're trying to do is we're trying to stop that erratic electrical pulses from quivering in the heart, and we want them to all work together at the same time. And we want to restore a normal electrical and mechanical function of the heart. That's why pads are either placed anterior, posterior, or like this. We get the passage again, stroke assessment here. We get the electrical pass. Wow, electrical pathway through the heart. I may need to go to bed. Um, we want to shave excessive hair before we place the pads. If you don't have a razor but you have an extra set of pads, wax the chest. Do not ever place pads over jewelry or medication patches. Do not place pads over an internally implanted pacemaker or defibrillator. Um, do not ever shock a patient if they are in metal bleachers or if they're in water. We want to dry them off before we shock them if they are wet. Oh, that looks like actually one of our guys. Um, yeah, congratulations. Okay. So we analyze the rhythm. Now, I'm going to warn you, certain police departments, I'm not being ignorant here, but I know a lot of cops, they like to play hero when it comes to a cardiac arrest. Oh my God, we saved them. Their AEDs sometimes are fully automated and they just shock without you hitting a button. So be careful of that. It's supposed to tell you shock being delivered, so stand clear because it will shock. But so when we analyze the rhythm and delivering a shock, what we want to do, we want to analyze the rhythm. And remember, we're big boys and big girls. So what we do is analyze. We determine the patient needs to be shocked. We resume CPR. We charge to the appropriate energy level. Once it's charged, hey, let's clear the patient. You're clear. I'm clear. We're all clear. We do a final look over. Shock back on the chest. Um, we want to do this every 2 minutes. And if the shock is advised or we determine we need to shock, we need to deliver it as soon as possible. If there's no shock and we determine, if we determine that they doesn't need to be shocked, or if you're using the AED and it says no shock advised, immediately back on the chest. Give me 2 seconds, guys. 1 second. Anybody that has children, if they have not reached age 4 yet, you're in for a treat. So we shock on the chest, all this fun shit. Now, checking for ROSC, return of spontaneous circulation, the moment we feel like God. So, one of the ways I'm going to tell you that you have ROSC when you're working a cardiac arrest, short of the patient just waking up, every arrest that you work needs to be worked with end tidal. If you get a sudden spike in your ETCO2, it is a very good indicator that you got ROSC. If your patient just spontaneously starts breathing, they're or you're seeing that like they're wincing to stimuli. So like every compression you do, they're kind of wincing. Stop. Or there's you feel a carotid pulse. It's a pretty good indicator that you got ROSC. Um, okay. Yeah, yeah, yeah. So high performance CPR is key no matter what you do. I don't care. Every ALS intervention in the world is not what saves a patient's life. High quality CPR and oxygen delivery is the two things that will save somebody's life 100% of the time. So you need to be able to work as a team to have a positive outcome. So a good day, a good training is group mega codes, not just CPR, but rotating through. So what we'll do is one of you guys will practice being the lead provider. And you're going to come in and you're going to assign roles. Start compression, start bagging. Let's get them on the monitor. And I will tell you, actually, the best people usually to learn that from are the dictation of the roles and how all of that works is usually our emergency room nurses and our ICU nurses. Those are my favorite people to teach ACLS to because they come in and they know it because that's what they practice doing. A lot of healthcare systems are actually going to monthly trainings with that, and it's actually something we're going to start doing down here at my department. Um, but you can use a checklist or a memory aid just to make sure everything's done. But practice makes perfect. So yes, it's nice to get that IV and get the meds on board, but CPR and defibrillation is key. But what you want to do, and this is learning your priorities, CPR, defibrillation, establishing the airway, providing ventilation, all take priority over starting an IV and starting medication. Again, the meds are not what save the life. CPR and oxygenation. Well, CPR shocking and oxygenation, but you get my point. Um, IVs are only started when you have enough people there to work the arrest that allow it to be done without interrupting or delaying the critical procedures. So, optimal successful resuscitation, the patient gets ROSC and is discharged from the hospital neurologically intact. I will tell you that very rarely ever happens. If ROSC is achieved, rapidly pivot to post-resuscitation care. Avoid hypoxia, avoid hypotension, transport. Um, just get them to the hospital. CPR in infants and children. 99% of the times it's caused by hypoxia. Um, so you can get things like foreign body airway obstruction. Um, I was working EMT in Youngstown. We went to Campbell. We had a kid who had severe asthma, went into um, status asthmaticus and ended up being in a cardiac arrest. Respiratory infections, drownings, electrocutions, overdoses, trauma, all that. Survival and rates are improved by bystander CPR. Sequence begins with chest compressions. Lone rescuer compressions are 30 to 2. When you get two rescuers and you're working a kid, it changes to 15 to 2 um, because you want to oxygenate the kid. That's restoring oxygen to the kid um, is is key. That's what's gonna save them. Remember, infants are under a year old, children are 1 year until they reach puberty. So infants, we check the brachial pulse. So two thumbs, center of the chest. Children, you check a carotid pulse. You can use one or two hands depending on the size. Um, Rapid intervention required for cardiac arrest. No shit. Rapid medical assessment. Obtain a history if it's possible, and try to figure out what happened when they went into cardiac arrest. You know, and I always tell people, hey man, like if they took something, I need to know. I might be able to fix this. Um, so we treat cardiac arrests and uh, we try to figure out reversible causes, and we call it the H's and T's. Well, the five potentially reversible causes of cardiac arrest, the five H's: hypoxia, hypovolemia, hypo or hyperthermia, hydrogen ions, so acidosis, or hypo or hyperkalemia, so high or low potassium. The five T's: trauma, toxin or tablets, thrombus, so stroke, ACS, pulmonary embolism, cardiac tamponade, and tension pneumothorax. So this is where I'm going to tell you there are ethical and legal considerations to everything that we do. You always follow your protocol to determine what you need to do. At the end of the day, you need to ask yourself what is ethically and what is morally right. If you have a family and are split on what they want you to do, you tell them, I'm going to start with CPR and ventilation, and I'm going to call the doctor and have the doctor make the final decision. If you have some and they're like, please, we know that there's no hope, call the doctor. I may not even start CPR in that case to honor the family's wishes. That's me. I'll take that risk. I'll take that chance of getting smacked by the doctor. We ultimately have to do what is right by the family. But we don't start CPR on patients who have rigor, who have dependent lividity, who have obvious decomp or injuries incompatible with life. So if they're decapitated, your CPR is not going to save them. Um, if you have a terminally ill patient, they could have a DNR or the physician's orders for life-sustaining treatment. Blah, blah, blah. What we see in Ohio are state DNR forms. Um, our job also isn't just resuscitation. It is looking after the well-being of the bystanders and the family members. You know, don't be the dick, especially if you're in Mahoning County and you don't have to transport the body. Cops aren't always the most warmest and fuzziest people to sit with a family member. If someone just lost their loved one that they've been married to for 50 years, you need to sit there with them. Help them make phone calls, call family members. The worst thing you ever have to do is tell someone that their loved one died over the phone. That I will tell you right now, that's the hardest freaking thing in the entire damn world. Um, it's something we'll go over in class. We'll actually talk about it Saturday. Um, for me being probably one of the bigger assholes on planet Earth, um, I've had people thank me when I've told them that their loved ones have died. So it's something that I learned from a very old paramedic, and you just have to have a certain way about doing it and about saying it. And especially if you're doing it in person, there is that whole interpersonal communication. You have to know how to talk to people. You have to be able to read body language doing this job. Um, and you always have to be able to, and this is what I always tell everybody, you don't ever just go in and say, sorry, we did everything we could. And I always tell you, if we terminate on scene, I will go in and I'll tell the family, I'm very sorry. We have done everything that we can. However, we wasn't able to get their heart beating again. They've died, passed away, whatever, however you want to word that. They need to hear one of those two things. Either they've died or they passed away. We've done everything that the emergency room would do. We've talked to the doctor, but unfortunately, there's nothing more. You know, if they want to stay and watch you work it, let them. Sometimes that helps. I don't recommend it, but yeah. But if ROSC is detected, continuously monitor the patient for subsequent deterioration and cardiac arrest. Just because there's a rhythm on the monitor doesn't mean it's a pulse producing one. Manage the airway and breathing. Consider placing an advanced airway if not already done. Do not overventilate. Maintain normothermia and manage any hypotension per protocol. And you need to learn to accept the fact that 99% of the time we're unsuccessful in resuscitation. Um, Patients who achieve ROSC rarely regain responsiveness. Permanent neurological deficits are common, but we want to manage airway breathing, obtain vital signs, continuously reassess, and if they maintain ROSC for more than 5 minutes, get a 12 lead. AMTs must rapidly identify and treat patients in shock and cardiac arrest to improve survival. Yes. In shock, priorities are to establish an airway, ensure the patient is adequately ventilated and oxygenated, and control external bleeding. Blah, 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 blah. Okay, so that's that. I was going to dive into another chapter. However, not going to have time for that. But what I want to show you is, so if you guys go to Google and you type in 2025 UH protocol, the first one that pops up, I believe, is this one. If you go to this protocol, here you go. Adult circulation and shock protocols. So you have shock guidelines, anaphylactic reaction, cardiogenic, hypovolemic, neurogenic, and septic shock. So it breaks this down, and this is actually a phenomenal cheat sheet for you guys. Um, so it breaks down cardiogenic, hypovolemic, and actually I think this breaks it down for signs and symptoms. Oh shit, hang on. Quick screen sharing. I hate technology today. Okay. So, any Hoosers, Google 2025 UH protocol. Click on it. Takes you to this. Scroll on down. Oh, let's play here. There it is. Adult circulation and shock protocols. You go to shock guidelines. And I think this breaks it down better for you guys with signs and symptoms for cardiogenic, hypovolemic, anaphylactic, aka distributive, neurogenic or distributive, septic distributive, obstructive. Um, these act well, the whole shock protocol, but this page here, um, and this page are a great cheat sheet for you guys. Um, as well as looking at this, the protocols and the treatment guidelines. It is a great study tool, actually. I will tell you that right now. Um, I will pull it up on my iPad, screenshot these. I'll have them printed off by Saturday, and I will hand them out. I wanted to dive into another chapter tonight. However, there is no way we're going to have time. Um, so if it is okay with everybody, I'm going to let you guys go. I'm going to go drug myself with NyQuil and Mucinex and go to bed so that I can be up at 3:30 in the morning to be at work at 4. Um, I'm not going to assign TXA for your pharmacology card yet. Um, we'll do that in trauma. Um, this will get posted and sent out Friday. I did send everybody the YouTube link. It'll be on YouTube before Zoom finishes its thing. So if you want to go back on and rewatch it, you'll be able to. Um, if you want to go ahead and get on Brady Lab and do Chapter 17, everything is open for you guys to be able to do multiple attempts now. And you can also print everything off as you do it. I did put that option on there. So even after you do it with the right answers, you can go back on, print it off. Again, great cheat sheet and study guide. But other than that, that is all I have for you guys. Um, so other than that, you guys can have a good night. If anybody has any questions, feel free to text me or email me. If I don't answer tomorrow, it's because I'm going to see Aaron Lewis. Um, but if not, I will text everybody Friday afternoon. We may start class at 9:30 again, maybe even 10, depending on how many labs I can get set up for you guys. I'm trying to give you guys the most use of your Saturday. If I can get everything set up the way I want, we'll start at 9, and I should be able to have you guys out between 2 and 3. Um, so, but I'll get that sent out Friday. But other than that, you guys have a good night. And like I said, anybody has any questions, feel free to reach out, text me, call me, email me, send me smoke signals.